these patients come in after a blunt assault or whatever it might be, for example, to the ED, to be able to connect with them. I mean, that's something that's really tough to share. And how do we earn their trust that we can help them and that they should trust us and that we'll protect them and give them shelter and food and keep them safe and their families safe too from the traffickers themselves.
Welcome to Evening Rounds, a podcast that takes you behind the scenes in medicine. Dr. Sigrid Burris, a trauma surgeon here at Loma University Health, talks to us tonight about the destructive power of violence in our community and what Loma University Health is doing to prevent it. Sigrid, it's awesome to have you on Evening Rounds. This podcast is something that we've really enjoyed doing, and you've been on our bucket list for some time. I was feeling a little sleep deprived last night with the time change and everything. I got like 5 hours, and I was like, oh my goodness, I'm going to have to be on camera. How is this face going to look with 5 hours of sleep? A little birdie told me, though, that you would probably be quite envious of 5 hours.
Very envious of 5 hours, but that's okay.
What was your schedule like last night?
I was on SICU call, so we do 24-hour in-house SICU call. And so it wasn't too bad, just the usual steady people coming in, needing care. So a couple of admissions, things like that.
So hold up. So SICU, is that like sick me, or what's SICU stand for the people that may not be aware?
So it depends on who you ask. So surgical intensive care unit. But if you ask my son, when I say I'm on SICU call, he means... because I say SICU call at home, and he'll say, oh, you mean I don't see you call. I'm like, oh, I know. So I'm like, oh, I'll see you tomorrow. It'll be okay.
He's got that figured out, right?
Yeah.
Wow. So then you were on call last night, and then this morning you were at your tattoo removal clinic.
Correct. Mm-hmm.
And then you'll go back to do more work after you're done with us.
There are a couple of meetings, but they are luckily Zoom meetings. So the only good thing that has come out of COVID is the Zoom meeting. So a little bit more work to do before the day ends.
So when you're on surgical ICU call, what does that mean? Are you just waiting for a phone call and you provide, or do you do, what do you do?
Yeah, so when we are on SICU call, we have our surgical ICU patients. So they're up in 7A. We share that place with Nemesis. And those are all of our trauma, ACS patients that require ICU level of care, neurosurgery, OB-GYNs up there, all the postoperative or preoperative patients who are on the surgical services. And so we, as providers, we have our ICU patients that we round on, take care of, hopefully get them better and through things and well enough to downgrade to the floor. But we also cover all the code blues that happen in the hospital. And then especially overnight when there's procedures that need to be done. Like last night, there was a central line to do in the MICU. So we go down there and help out the residents.
So you are doing all sorts of different things on very sick patients, trying to get them less sick so they can move towards the transition of going home?
That's the goal.
It seems like you have a real passion for trying to keep people out of your area.
Yeah, I mean, I always say no one actually wants to be in the hospital, except unless you're having a baby. Because it means something good didn't happen, right? You're ill, you're in the hospital, you're not doing well. And even if it's something minor that you'll recover from, life is much better if we didn't have to go through it. So no, definitely. And especially for trauma and ICU, we're super sick patients that end up with us. And so really trying to get the patient better, but also supporting the family through all of it. Because that is so hard. There's so much uncertainty. And, certainly we, can guide the family through a lot of things, but I don't have all the answers, especially when it comes to some of the sick patients in terms of how they're going to do.
Yeah, absolutely. So what are you doing in your work to try to prevent trauma? It's really unique to me that you're trying to keep people out of our hospital. So how are you doing that?
Yeah, there's a lot of things that myself and many of us are doing to help with that. So because as much fun as it is, if there's a trauma, like a gunshot wound that comes in to the trauma bay that we get to crack the chest on and take to the operating room, it's still really something awful that's happened to someone and obviously their family as well. So if we can prevent that would be really ideal. If I no longer have a job, that would be amazing because it means that everyone is healthy and doing okay, and not getting injured and needing to come to the hospital and have, all the trauma that comes with that as well. So there are a few things that many of us doing. We have an amazing team to help with all of this. So just to name a few, Andre Ike and Connie Cunningham, Tanya Hanks, they're just amazing people who've been so supportive in helping build the hospital-based violence intervention program. We have Dr. Bellier, too, with Charles, who's our community health worker, who's really partnered with us here in the hospital to meet with our trauma patients, especially those that are violently injured, to work on identifying their needs and connecting them to resources in the community to prevent recidivism. And so that's what the whole trauma prevention program is really based on.
So is most of what you take care of in terms of trauma in the hospital, is it accidental or is it a violent act?
Most of it is accidental still. I mean, there's a lot of falls, a lot of motor vehicle accidents, pedestrians versus auto. So that is definitely the bulk of it. I mean, our penetrating trauma rate, so the gunshot wounds and stab wounds, is right around 12, 13, 14%, kind of depends on the month. It did go up quite a bit during the peak of COVID, up to almost 20%. But a lot of it is definitely accidental, although there are things that we can identify in the hospital that might have, prevented this from happening, whether it's, the drug use, alcohol use, or just, safer driving habits and things. So there's still a lot of things that can be addressed to even prevent some of the accidental things like pedestrian accidents or car accidents.
So, I mean, the obvious trauma is the physical trauma. Mm-hmm. I suspect there's equally amount of emotional trauma that comes with this. So as a team and you as a physician, you can impact the physical trauma, but how do you heal the soul?
Yeah, and that's exactly right. I mean, what we are trained to do in residency and fellowship is to impact that physical portion of it, right? Have a hole, fix the hole, and then discharge them. But that doesn't address the bigger picture. And that's why we have such high recidivism rates, or patients who after a trauma, they don't go back to normal life. They don't go back to their jobs. There's so many things that are going on, whether it's, physical pain, but also the emotional pain, whether it's PTSD, anxiety, depression. We see really high rates in our patients with that. And so being able to identify that in the hospital and then connect them to the resources outpatient so that they can get the help they need so they don't have the long-term problems. And that's definitely one of the things that we are focusing on doing research on, interviewing our patients to find out, do they have PTSD? Do they have acute stress disorder? And be able to connect them to the resources. And with the funding that we now have through the CalVIP grant for our violence intervention program, that's one of the focuses, is to really be able to identify those mental health disorders in patients that either were pre-existing or have developed since the accident itself, to be able to then help them out in the long run. Mm-hmm.
That's incredible. And I know you just mentioned you were, the major champion and the reason we have that grant. You have two major grants, one for your tattoo removal program and then the violence-based prevention. Tell us a little bit about kind of those two programs and maybe some things you've seen from those programs.
Yeah, the violence intervention program has definitely been something that is continuing to grow. And we're so excited that we get to hire some additional violence intervention professionals to be able to connect with our patients because, we don't all have time to do that. And sometimes, we don't have that lived experience to make those connections either. And so having those violence intervention professionals there is going to be so tremendous to be able to really, I think, reach out and help a lot more patients inside the hospital and outside the hospital. One of our earliest patients that I remember, this is now a couple years ago, he had gotten shot in the belly and had many, many, many surgeries. It was just back and forth, and I just can't even imagine that, right? Where you say, well, one more surgery, and you don't know when it's going to end or when you're going to get better and go home. He did eventually, get well enough that we were going to get him home, and I remember meeting with him and kind of getting all that planned out, and asking him, what can we do to help you so that you don't have this happen again? Right? Because that's, we can't fix what happened already. So how can we keep it from happening again?
What a basic question, but such an important one.
Yeah. And just trying to be able to identify what needs we can help them with, and connecting with our community violence prevention programs as well. Went down the whole list of what we can do, and finally got to, what about, a GED? Like, our community programs can help you get that if you're interested. And he was not super engaged initially until I mentioned that. He was like, oh, I might want that. And so we were able to connect him and our violence intervention professional who works with the community program. She actually knew him. He had been previously in the program and then kind of fallen by the wayside, and was able to re-enter. And so we were really, unfortunate that he had to get shot to end there, but he was able to get his GE done. So it was pretty amazing.
It's life-changing.
That's awesome.
Yeah, it's fantastic. And that's the whole point of it, right? Is to say, hopefully you don't get shot to begin with, but even if something bad happens, like, hopefully we can connect and support you along that process of healing to do something to not have this happen again.
Man, that's whole person care if there ever was.
That's huge. And it's so interesting because, like, you're a surgeon, right? But this other aspect of this care was him getting his GED. That's so incredible that you get to be a part of that huge spectrum of care.
I think that's the thing is, even though, I'm trained as a surgeon and our focus is to repair that physical trauma, there is so much more that goes with that, obviously. And we're finally getting to that portion of recognizing our contribution to the whole person care of it all, right? So to not just fix them out, ship them out, because that doesn't really address the underlying problems.
There's an old book or article, I can't recall right now, but the title was On Doctoring. And that was exactly that, right? The science of medicine mixed with the art of healing is powerful. And that's really cool what you're doing. I was struck by something I think you said in the first one or two sentences of our conversation today. And that was, I think I heard it correctly, a tattoo clinic removal.
Yeah.
So how do you do that? And why do you do that? And what are the folks that are coming to see you? I'm very intrigued by this. I didn't even know we had this.
Yeah, it's pretty new. We started it actually January, and so we have had a huge interest in it. And it stemmed out of seeing our patients in the hospital who have tattoos for many, many reasons that they find either socially unacceptable or gang-related, have really prevented them from kind of moving forward with their life. And we didn't have anything, right? And so, there's other organizations and, obviously private clinics who do tattoo removal, but they're really, really expensive. And a lot of our patients and most of us simply can't afford that. And so, and insurance doesn't cover it either. So you're saying, well, what can we do to help, right? Like, you're our patients, we're here to help. So what's our role in this, right? And so, so those patients, they, if they have, a tattoo on their face, whether it's, teardrops or they're, the gang that they're part of. We've had some individuals too that have been victims of human trafficking that have really visible tattoos that are a reminder of their past. But then also, it's hard to get a job if you have these tattoos that are so visible. It can be really tough. And so being able to offer that service to them. And so it's a laser that does the tattoo removal, breaks down the pigment.
How life-changing that must be for someone who's wanting to remove that trauma, that memory of maybe that past or what that past meant to them. Do you have just so many, I'm sure you have hundreds of touching stories that have come out from that program.
Yeah, there are a lot of patients who've come in that some of them are really open about their stories and others a little bit more guarded because that's really personal to talk about. But certainly, we had one gentleman who had tattoos all over his face and really, struggling to just kind of move forward with life because there's this constant reminder of his past. And again, when you're walking down the street, people look at you differently and they treat treat them differently too. Because, unfortunately, we make assumptions about others based on how they look. And so we completed his sessions, and all of the tattoos are off really on the face. And so, he just started crying. He said when he looked in the face, he was like, I can see my face again. And it's amazing. And, it doesn't remove all of the struggles because there's still a lot that they have to get through. But at least that physical portion of it allows them to hopefully move on a little bit more.
Wow. I mean, you talked there about a lot of different elements, but the human trafficking portion of that's something that I feel like you've really been passionate about trying to teach and trying to educate on that. Tell us a little bit about your role in that.
Yeah, it's something that I think we really underestimate and are not as aware of as we should about how many people are trafficked. And so, because it's not part of our environment that we necessarily deal with every day, although we certainly see them as patients, whether they come in after blunt assaults or just for general primary care visits, OB visits, things like that. And so, knowing kind of the fact that it's out there, it's the second most common illegal activity in the United States. I mean, it's huge. And, I just gave a talk at the AAST, which is our big trauma society meeting on human trafficking. And, just to be able to educate others to say, this is out there and it's really common. And this is the things that we can do as providers to identify it and then provide resources for it. And our emergency department is doing a lot of work with it too and educating their nurses and other staff. And so it's really luckily getting a lot more education out there to everyone.
I mean, I'm almost afraid to ask the question, but I think I'd be remiss if I didn't. So when you do tattoo removal on someone who's been human trafficked, is this like a branding stamp on them, or what is this?
It's exactly what it is, unfortunately, because the tattoos that are used by the trafficker, they put tattoos on these women to show them as their property, and they are usually symbols of money to show that you are mine and you will make money for me. And so barcodes, dollar signs, money bags, it's horrible. And it's this whole different world. And we met one lady, I mean, there's many of them, but her trafficker had her tattoo his name on her hand. And, even though she's luckily no longer, that's not part of her life, she was able to get out of it, still had that reminder. And so, being able to remove that from them to just help with the emotional trauma of it and then move forward is really pretty remarkable.
Oh, my.
It's just wild to think that that's just not even a mile away from where we sit. I mean, this is our town. This is our backyard.
That is and that's the thing, right? I mean, these are our patients, our community, and that's the whole point of, we're taking care of all these patients. And sometimes you take a step back, you say, what else can I do? Because sometimes it doesn't feel like enough, and we can always do more, right?
I just feel like that is so incredible that you have that spirit, right? That you're here for that, to just every single day live, and you're living that in what you're doing. It's just so incredible.
And we have an incredible institution that supports all of it. So, which makes it easier when you're with like-minded people as well that kind of support you with, all of these processes.
So if someone's listening to this and has a tattoo that they want removed, how do they go about finding you?
Yeah. So luckily, it's not just me. So there's a whole group of us. But we have our injury prevention at llu.edu email. And so that email allows them to then get in touch with myself and Andre Ike, who runs the tattoo program with me, to be able to then get into being evaluated for tattoo removal.
That's wonderful. We'll make sure that that's on our podcast.
Yeah, absolutely. I mean, the impact you're having is so great. Did you, when you were a little tiny, Dr. Burris, think you'd ever be in this position?
No, Not to this extent. I think it's definitely a growing process. When we are training, we are so sometimes focused on learning the physiology and the pathophysiology of all of these organ systems that the human aspect of it is not always taught as much. And so it, you just focus about going from one test to another. And so to be able to then say, okay, I learned what I need to learn. Like, I know how to operate. I know how to take care of patients and fix their injuries. And now let's look at the big picture and address that.
So you are a surgeon that is on doctoring. You're also an educator here on campus. So how do you take those skills and inspire the next generation of physicians to not just fix the body ailment, but address the entire person?
I think when we approach a patient as someone, who has family, who's loved, and is more than just a diagnosis, but we look at them as, if this was my loved one, what would I want them to have? And then whether, obviously the correct treatments and interventions, but also how would I want to be talked to? How would I want to have the medical team engage with us? And I think it helps from that standpoint, because then we can see them as a real person and think beyond the like, okay, I'm going to take out your colon. Now we're done and you can go home.
Mm-hmm.
So.
Yeah, exactly. I heard a personal story from my husband who benefited from your teaching one of his advanced life-saving courses, recertification. And he said, she's genuinely the most engaging. You want to listen to her. She's so smart, but she's also just so kind. And I know you're obviously a very humble person, but, I think that really translates to how you're bringing up this next generation and how you're teaching. Did you come to Loma Linda specifically to teach, or why did you choose Loma Linda?
It's a good question. I mean, there's, I think, a couple of different things that ended up or made it so I ended up here. I was in private practice first, and, just for many different reasons. My parents were ill, and so just needed to find a job and have some flexibility, and ended up in private practice. And as much fun as it was very focused on just, you show up for your shift, you take care of what's needed, and then you go home. Mm-hmm. And that was it. And which is great. And that's wonderful. And I think for some people that's fantastic, right? But for me, it wasn't quite enough. And I really, really missed teaching a lot, and having residents and having medical students and watching them learn and get excited about it, to say, not just like, oh, I did well on my test, but I took care of this patient from the beginning to the end and they got better. Mm-hmm. And to like watch that process. I mean, that's what we're here for, is just to kind of always try and do the right thing and do better, and then watch our patients hopefully get through and go home.
Do your kids or your neighbors, do they know the extent of what you do?
My kids definitely, for sure. My neighbors to some extent, yeah. But absolutely. I mean, I share stories with my kids about what I do and the traumas that come in, and the good ones, and then also the ones that don't make it, because life is rough, and it is sometimes really unfair. And I think it's important for us to understand that, and they're old enough and to understand that. I think the other thing too is, when we're not at home, that they understand that I'm not home for a good reason, because I'm hoping to take care of others. And the same thing goes for all of us when we're at work, right? We're here to help each other out.
I love that. And I love that you're showing them that hard work, and you're showing them that dedication to saving human lives. And I think what you said is so true. Trauma, in a lot of ways, seems so unfair. Like, obviously any diagnosis is hard to take, but trauma is so sudden a lot of times. And it's something that that just seems to just happen out of the blue.
Yeah.
And so that must be very hard when you're talking to families, or even your own family, about just different things you saw during the day.
When things don't go well and patients don't survive, how do you teach your students, your residents, that it's okay to be human and to feel.
Yeah. I mean, I think it probably makes us better and stronger doctors when we do, because that's what our patients feel, right? And that's when you give them a bad diagnosis, or in our families for sure, when these unexpected things happen, I can't explain why, but it happens, and so to be able to support them through that and hug them and cry with them and tell them the truth too. I mean, when we don't know what will happen. Some of these head injuries, they come in and I don't know if they're going to wake up, and we certainly hope they do, and we'll provide everything that we know how to do, but we don't. And to kind of sit with the families and grieve with them and also hope with them though too.
So the Evening Rounds podcast, we thought a lot about the title of our podcast, and Evening Rounds as a physician for me was always a time of reflection and meeting with families and kind of wrapping up the day. But that's just Anthony Hilliard's sort of concept of Evening Rounds. When you hear the term Evening Rounds for you, I'm curious to hear what it means for you.
Well, usually I don't finish rounding till the evening. So, with as many patients as we have on service, and I tend to talk a lot. So my rounds take a little bit longer than other people's. But I think it's a time, when I think similar though to what you said, where you go back to some of those patients, especially the ones that you're worried about or didn't have time to fully engage with the family, and to sit down and say, you know what? I couldn't sit down and go through all this with you, but now I have an hour because I'm done with my workday. So let's go through this and let's talk about it, about what the prognosis is and what, where we're going to go from here. So, and to do so in a hopefully uninterrupted manner. So I think to spend that extra time that we don't always get to spend on rounds during the day when it's a little more rushed.
Well, Kelsey, I don't know about you, but if I was on Dr. Burris's rotation, I wouldn't mind that the rounds would take a little bit longer than maybe some.
Absolutely.
Can you pass that memo along?
We'll tell you right.
That's right.
Well, we can't thank you enough for spending your evening, one of those precious moments away from your family with us. I think many who will listen to this will be as blessed as we have been today.
I really appreciate the time. It's been really fun. Thank you.
Thank you.